Good morning, everyone. Today, Lauren, Melody, and myself, Tiffany, will be presenting on Kawasaki disease, or KD for short. Today, we will explain Kawasaki disease, including the pathophysiology, etiology, and at risk groups. Additionally, we will recognize the clinical manifestations of the disease and learn of the different treatment interventions. We hope that through this presentation, you all will be more educated on this rare disease in the event that you have a patient or child that is affected and needs your care.
Kawasaki disease, also known as Kawasaki syndrome or mucocutaneous lymph node syndrome, is a rare illness that is categorized as an acute systemic vasculitis. It is an acute systematic inflammation of the vessels with an affinity for medium sized vessels such as coronary arteries. This disease is most common in infants and toddlers aged from 5 to 6 years old. According to Haftel, it is the leading cause of acquired heart disease among children and occurs more often in the winter and summer months, affecting 6 per 100,000 children.
The cause of Kawasaki is unknown, but theories suggest an infection is the main trigger. KD acts on medium sized arteries, such as the coronary arteries, and can cause coronary aneurysms. When triggered, the vessels are infiltrated by monocytes, IgA antibodies, neutrophils, lymphocytes, and plasma cells, which weakens and damage the walls of the arteries. Theories also suggest that triggers are caused by infections, which include species from Staphylococcus, Streptococcus, and viral. Antigens in the body recognize the foreign objects to then create inflammatory responses. Instead of directing the attack to kill the foreign objects in the body, the immune system attacks the medium sized vessels temporarily, which include, again, the coronary arteries. This can lead to destruction of the elasticity and the collagen in the walls, resulting to damage to the structural integrity. Even with the repair, ballooning or bulging, otherwise known as aneurysm formation, occurs. The etiology of Kawasaki disease is still unknown, though experts believe that an unknown organism triggers the intense immune response. However, it is most commonly seen in children under 5, although children over 5 may sometimes get it, being more common in boys rather than girls. And while any race can be affected, it is more seen in Asian and Pacific Islander descent. Although Kawasaki disease is not contagious, siblings of patients with Kawasaki appear to be at a significantly higher risk of also developing KD due to genetic susceptibility. According to the National Institute of Health in 2020, KD has now been seen associated with the COVID 19 infection in children as well. It is estimated that at least 3,000 cases of Kawasaki disease are diagnosed every year.
Diagnosis of Kawasaki's disease is made when the patients have a persistent fever lasting longer than 5 days and is typically accompanied with the following: a polymorphous rash at the trunk, extremities, or groin, non purulent infection in both eyes causing severe redness, changes in the oral cavity such as a reddened or cracked lips, and a phenomenon causing the tongue to resemble a strawberry. Children with Kawasaki's disease may also exhibit extremity changes resulting in erythema, edema, and peeling of the fingers and toes that oftentimes extend to the palms and soles. When in doubt, remember the mnemonic crash and burn, as seen in the photo to the left. The nature and order of these manifestations are typically predictable, making it easier to diagnose Kawasaki's. If a patient has 4 of the 5 symptoms from the crash mnemonic, they are to be diagnosed with Kawasaki's. However, if the patient has a persistent fever but only meets 3 of the crash features, they are diagnosed with incomplete Kawasaki's. A diagnosis of atypical Kawasaki's may be considered if the febrile patient presents with findings that deviate from the typical findings of the disease, such as renal impairment. Other characteristics include GI related issues like diarrhea, nausea and vomiting, and abdominal pain, respiratory problems causing coughing, and rheumatic issues like joint pain and swelling. Because this disease is most prominent in patients younger than 5 years old, findings are the same in most cases. Though rare, the disease can also be observed in patients older than 5 years. Clinical features in this population present similarly. However, those 5 and up are less prone to developing coronary artery aneurysms as they get older. As Melody has mentioned, the major concern of this disease is coronary aneurysms, but not all children experience the vascular changes. In the case that the disease advances, prompt treatment is vital to reduce the risk of aneurysms.
Lab values reveal elevated white blood cell count, mild to moderate anemia, and severe thrombocytosis, or a platelet count of 500,000 to 1 million. The CBC may also reveal high erythrocyte sedimentation rate, or ESR, and elevated C reactive protein levels, or CRP. Echocardiograms are also indicated to acquire a baseline image of the heart or to measure if the disease has progressed in the arteries. Other pharmacologic treatments include 4 high doses of aspirin in conjunction with an infusion of IVIG or IV immunoglobulin. A normal dose of IV immunoglobulin is 2 grams per kilogram per dose. IVIG is used prophylactically to prevent coronary abnormalities and to reduce the risk of coronary artery aneurysms. Corticosteroids are used as an adjunctive therapy to treat Kawasaki disease and prevent further abnormalities of the heart. Other treatments include close monitoring of intake and output, administration of IV and oral fluids, preparation for ECG, close assessment of the heart rate and rhythm, and watching for signs of heart failure.
With Kawasaki's disease, it's important to monitor temperature, especially in patients vulnerable to temperature changes such as neonates and infants. With this in mind, our nursing diagnosis is hyperthermia related to inflammatory disease process, as evidenced by a fever exceeding 101.4 degrees Fahrenheit that has persisted for more than 5 days. To promote heat loss through conduction and evaporation, periodic sponge baths may alleviate febrile episodes. Secondly, we will set aside time to promote adequate rest and attempt to reduce the body's metabolic demands and oxygen consumption.
Including the patient's family and caregivers in the education process is a key component in the patient's care. After assessing the patient's health literacy of the disease, it's important to remind patients and their families to avoid any live immunizations in the 3 weeks preceding and 3 months ensuing IVIG therapy. IVIG can change the immune system, making the vaccine less effective. Furthermore, the patient should be informed of the signs and symptoms associated with the flu, chickenpox, and MMR. Exposure to these viral infections should be reported to prevent further complications. Patients and their families should be encouraged to continue low dose aspirin therapy at home to prevent blood clots. Warn the individuals that ibuprofen and other nonsteroidal anti inflammatory agents should be taken with caution at this time because these drugs may interact with one another. Because this disease attacks the vascular system, the patient should also be encouraged to follow a healthy diet and lifestyle. During exercise, the patient should be allowed periodic rest periods to conserve energy. Most children will recover, but follow up care may be necessary to assess the status of the patient's heart throughout their lives. The patient with aneurysms is at an increased risk of having a heart attack. Therefore, patients and caregivers should learn CPR and have an AED unit on standby in the event that the child has a heart attack. Finally, the caregiver should be educated on the symptoms of aspirin toxicity if aspirin therapy is received at home. These symptoms include headache, dizziness, confusion, and tinnitus.
To wrap things up, we'd like to remind you of these three things. This disease is typically seen in, but not limited to, children under the age of 5 and of Asian descent, the acronym CRASH and BURN to identify the classic clinical manifestations, and lastly, providing patient education to clients and their caregivers will ease anxiety, nurture the patient's trust, while also giving them the power to have a say in their own care. We hope this information served you all well, and we thank you for listening.